We're at the CROI in Boston, and we're here with a local Bostonian, Larry Madoff, who's with the Department of Health, Massachusetts. And we're here with Jean-Francois Etard from the IRD in France. And both of them are we're all going to be speaking about the kind of an update on Ebola, at least the pieces that of what we know, or you know. We hope that we can cover this in a way that will satisfy our consumers and viewers that are interested in this subject, which we all had people worried about it, and yet they don't worry about getting a flu shot. That's scary. So who wants to start off? Do you want to start off, Jean-Francois?
If you wish.
Okay.
Thank you very much, Fred. I'm very happy to be invited to this talk and this morning discussion with you. So, as you know, our group is working mainly on the survivors in West Africa, and particularly in Guinea, where we are working since now more than 1 year. So we launched a cohort study, to enroll the survivors from Guinea, and to look at their symptoms, clinical sequelae, long-term persistence of virus in different bodily fluids, but also psychological consequences and social effects of the disease at the family level or individual level. That's in short.
So are you, the work that you're presenting here at the CROI is
yes.
in more detail?
Yeah, yesterday night we did this presentation.
Yeah.
Okay. So in more details, we enrolled now as almost 500 patients. As you know, in Guinea, we have more than 1,200 survivors. There was discharge after 2 negative PCR and blood, and we enrolled them within, well, it depends, but half of our participants were enrolled within the first 7 months after discharge. So it means that we have patients just out of their treatment unit, and one patient long after their discharge from the treatment unit. So we have a whole range of symptoms, very early symptoms after discharge, as well as late symptoms after discharge. What we observed is minor or mild symptoms, I would say, general symptoms like fatigue, of course, anorexia, joint pain, already known, muscle pains, of course, headache, anorexia. But the most severe symptoms are really on the psychological side, and eye problems with uveitis, frequent uveitis, which could be more severe with cataract. We have some cases of cataracts, post-inflammatory cataract. So we are very concerned of that. The other important aspect we want to detail more is neurology, neurocognitive disorders. So we are just implementing specialized consultation and special examination for the neurological component of the survivors. But one of our main input, I would say, because we are a multidisciplinary team, is social impact of the disease among the family of the survivor. So we are discussing, we have very close interviews with the survivors to know what did happen in the family, for example, how many cases, how many deaths, what is, how do they live now with no money, very frequently. All this kind of social impact, very, very important. And biological and parameters, and of course virus persistence in the bodily fluids is, of course, at the top of the agenda.
So how long do you follow this out?
Well, the first inclusion was just a little less than 1 year ago. It was mid-March 2015. So we plan to follow them for 2 years. 2 years. So since we started in March 2015, I think we will go until mid-18, something like that.
Okay. So you think that that will be sufficient to really see the end of the symptomology, or?
Well, what do we observe? It's a decrease in trend with time after discharge. In terms of psychological disorders, the depression is quite high at the beginning, just after the early after the discharge. After it decreases with time, for the virus, as you all know, that there is a decrease in trend in time in the virus persistence. There is a clear viral clearance in the body, of course. In the semen, you can see very precisely that we have a decreasing trend in the viral load in the semen when it's positive. And the proportion of positive men decreased with time after onset or after discharge. So we think, apart from rare cases of reactivations, we never know. We know the story of the Scottish nurse, of course, but we didn't see that. No reactivation. Very clinical sequelae, clearance of the virus, and really one of the most important impacts is really social impact. So we can manage uveitis because it's very sensitive to corticoids, for example, apart from complex cases as with cataracts. We need to have psychologists with us to take charge of the patients, and of course, to follow closely the virus in the bodily fluids. But really, we have to stop at one point. For example, after 2 or 3 negative samples, I think we will stop to check the different bodily fluid, for example.
So is the pathogenesis always very straightforward? In other words, at some point you see this is a survivor, or it's going down the path of not surviving. Is that what you would see?
We have only survivors in our courts. We work only on survivors.
Right, but I'm saying, I guess I'm just asking a bigger question. You know, at some point you do see in Ebola that the person is a survivor or they're not. It doesn't go like a survivor and then all of a sudden goes back to it.
No, really no. We have not seen that, no.
And the treatment continues? Is there
standard treatment? There is, of course, no, as you know, no antiviral drug. No, it's only a treatment if case of headache, in case. The only point which is a little bit more special is regarding the eye problem with corticoid, etc., etc. But for example, we don't use any antiviral drugs in the eye, for example. Okay. And neither other antiviral drug for the body. We don't use favipiravir, for example, only any of those drugs at the moment. But as you know, there is a vaccine initiative to immunize the contacts of the cases, okay? But no, the contact of the survivors. If the survivors, for example, is still shedding virus, there is a recommendation in Guinea, for example, to vaccine his or contacts.
Right. So there is this incubation period or the period where they're infectious.
Well, you know, if there is some virus in the semen, we are talking about sexual transmission. Right. That's the point.
I see. Okay. And Larry, you're bringing to us the perspective from a state that has had an experience. We worry about this so profoundly in this country, and yet there's so small of an incidence that it's almost crazy. But it is nonetheless for that person that or that family that there's this big concern.
Right. The concern in this country, I think, was out of proportion to the actual risk that was seen here. There was, and as a public health department, we have a responsibility to try to assess the risk and really accurately portray the risks, but also to some extent to respond to a public perception and to try to quiet fears of the importation of Ebola, which was really a major concern among the American public here, as reflected in very exuberant news coverage of cases in Africa and the extremely rare cases that actually did occur in the U.S. We were fortunate that there were no cases of Ebola in Massachusetts, but nonetheless we needed to work with a variety of stakeholders and partners to try to be ready in case there were cases, to have hospital facilities ready, to have testing capacity for people who returned with a question of Ebola disease, to be able to have adequate infection control measures in place in case there were a case. And because we in Massachusetts have a large number of healthcare workers, it's the home, for example, of Partners in Health.
And that's what you're mostly concerned about for when
Well,
they're returning.
Certainly they
Is
were
the
a
risk.
category of concern. The health department here monitored about 1,000 return travelers from the 3 affected countries in West Africa during the last couple of years, during when we really became aware and when the outbreak grew.
Right.
And so we monitored all of those people daily during the potential incubation period of Ebola. We had a higher level of monitoring that was required for patients who we actually perceived at being at some small risk, healthcare workers by and large, who returned. And those patients we actually observed daily during their incubation period time. And
So
as I
how
said,
did that work? Did you go to their home and traveling nurse?
No, by and large, we did it by Skype. We actually would be in contact with people by Skype. We would observe them taking their temperature, and just be able to sort of eyeball that they were well and not.
But these
really
are healthcare
concerned.
workers for the most part.
These are healthcare workers,
They're familiar
right.
with the procedures.
Absolutely, absolutely, and were extremely responsible and understood the need from a public fear perspective of doing what they did. I think in retrospect it's easy to say that this was perhaps an overreaction, that this kind of intense monitoring really wasn't necessary given the magnitude of the problem, but at the time, you do have a responsibility to address public fears.
And there's always that issue of the congressional hearing that I told you so, we should have done this or that. I know
Right.
they asked Tony Fauci to come to the hearing, and he did present it. Of course, they asked, one of the questions I think they asked him was, how many quarantine or isolation facilities do you have? He says, we have 2.
Right.
And that's maybe appropriate because that's where we're at. We're very small numbers.
We had a handful of people. We had, in Massachusetts, we had one physician who did become symptomatic in Africa and was treated in the U.S. and then returned to Massachusetts and actually has had some issues subsequently, but has done well overall.
So he was mentioning earlier that there's this long-term follow-up because it's not just you're done with it, like getting over the flu or whatever. There's this long-term return to more normal. How long does it take till you can get back to real normal? There are eye problems that go on, do they persist forever? Or
I think Jean-François would be better to answer that question. I have a very limited experience
because that's what
in
your
this.
study was. You were following doing the follow-up.
Absolutely. Yeah, for the first case of uveitis, there is a protocol, a treatment protocol in West Africa involving the US physicians too from Liberia. So the first data showed that there is very good response to corticoid, for example, without antiviral drug. Within a few days of treatment, there is a lot of improvement of the uveitis.
So it suggests that it's primarily immune-mediated rather than active infection,
absolutely.
would you say?
Yes, absolutely.
Yeah.
So the goal is to, would you say that if a person becomes infected, the earlier you get to treat, the longer you leave them with disease without attending or without treatment, without just doing what you can for them?
The problem is we enrolled the survivors entirely on a voluntary basis. So we did not catch them just at their discharge from the treatment unit. So we saw, and we still see complications, CKLA, long after their discharge. So we are taking in charge those complications. It could be 6 months after. Half, for example, for uveitis, half of the cases we observed starting within the 3 first weeks after discharge. But we have uveitis long after, even 6 months after, even more, yeah. So it's really unpredictable when it could occur. That's why we think we have to follow those patients, the survivor, regularly, at least every 3 months or every 6 months, everything is okay. But we can still diagnose or catch uveitis long after discharge. But the treatment itself, it seems simple and well responding to standard treatment.
So the eye problems are the most persistent?
Yeah, we think so. Psychological eye problems are important.
So do you have any other research that you're looking at that you feel is necessary to identify issues?
Apart from the neurology, we have to look more closely. Neurocognitive, I would say, and social aspect. I think we are going to move now to the contacts of the survivors. That's our next step for us, is to check if there is something going on. Are they well? And the problem behind, we think, and there was a communication yesterday, perhaps there were asymptomatic cases of Ebola.
So it can be a person who could be a carrier.
Or post-symptomatic who could be carriers.
Carrier and not be, and transmit it without being symptomologic.
Absolutely. So we like to check up those contacts, at least antibody tests and bodily fluids to be sure there is no problem.
So we are not able to answer that question yet.
Not
needs
yet.
to be answered.
Not yet, Fred, no.
But it is interesting to understand the epidemiology and the pathogenesis of this disease. Clearly, that it will be helpful to the population.
I think we are learning by doing, same step, same speed.
So I know we're going to talk with Larry separately in a program on Zika, but there's always something coming down the pike, and we always have to be on the forefront of understanding what it is we're dealing with. And the first thing anyone does is get fearful of it. You know, I know when I went to Australia, all I got on the airplane going over was all the bugs that are out there that can kill you, the spiders and the snails and everything else. So the fear of the unknown is, I guess, what we deal with, that has this psychological problem that makes the public so hyper persisting the worry and the frightening experience, and even dramas that played out with the doctor in where was it, in New Hampshire, the return that was on TV, and she didn't want to be quarantined.
Yeah,
she was taking bicycle rides.
Casey Hickox, to Maine actually. She went to
we want to do the right thing, and I think that's like you said. You try to do the most reasonable approach.
The irony is that I think Jean-Francois and I trained in an era when infectious diseases were perceived as being less of a problem, that these were going to go away, and that we were going to have to worry about things like heart disease and cancer, and that infectious diseases were really solved. You know, I'm talking about the 60s and that era. And then, I think HIV kind of was a wake-up call that infectious diseases were going to be a persistent and troubling problem.
And it continued because we thought it was going to be solvable, and then it wasn't.
Right. And we recognize now that microbes are a very resilient and powerful force.
And evolving.
And constantly evolving. As one Nobel Prize winner put it, it's their genes against our wits. And they have the capacity to evolve rapidly and change and emerge and cause problems. And so it's something that we have to be vigilant about always, and it makes our field interesting. But thank you from the science perspective and for the health department perspective, and we appreciate that opportunity to visit with both of you. Pleasure. Thank you very much.
Thank you for the pleasure.
Thanks for having us.